In today's video, we're going over the best evidence-based treatments for patellofemoral pain. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists, and we work at Champion PT and Performance in Boston, Massachusetts. We go through the literature. We figure out the best treatments for you. We try it on our patients. We make mistakes so you don't have to. How you doing today, Kevin?
Doing well, man. I'm really excited to get into these treatments here. I think big cliffhanger from last week.
I know. We left people hanging. They had no idea how to treat this condition. We just told them how bad it was, how to diagnose it, and then no help at all.
Right. Yeah, this will be good. Patella Pope's gonna drop some bombs here.
I'm pumped. And I said this in the last episode, but I've been doing literature reviews on patellofemoral pain for the past about a decade now, and it changes a little bit over the course of time. It's always fun to keep up with the new papers that come out. So I'm going to present what I have learned, and I'm also going to present some of the newer stuff, and then hopefully give you some insight to how I treat on a regular basis. But I do case studies and that type of thing too. So if you guys are interested in seeing exactly how I treat, I'll leave a link in the show notes for some of those case studies. All right, let's summarize. What are we going to go over today? So we're going over all the best treatments for patellofemoral pain. We're going to talk about patient education. We're going to talk about exercise. And we're going to talk about how to modify movement and whether or not you need to modify movement in your patients. I'm talking dynamic knee valgus. Talk about exercise for the hip, mostly posterior and lateral strengthening. Exercise for the knee, mostly the quad. Exercise for the foot, which is a bit of a new kid on the block in the past few years. And we'll talk about blood flow restriction because there's more research coming out about that, which is pretty cool. We'll talk about orthoses. So things like straps and braces, should you use those in your patients that have patellofemoral pain? We'll talk about activity modification, and we'll talk about things like load management. We'll also talk about gait retraining, which is pretty good. We discussed this in the last episode, but patellofemoral pain, also known as runner's knee. Can we modify the way we run to reduce pain and improve our outcomes? We'll talk about that. Taping. Taping's been around for a long time. McConnell taping. Should you do that? Talk about manual therapies. Is that something that's beneficial for patellofemoral pain? And lastly, we'll talk about modalities. Everyone's favorite. Is that your favorite, Kevin?
Yeah, I was just going to say I'm excited to get into this because all I use right now is modalities. So I'm hoping you can educate me on other things I could maybe use, but it's just been modalities up to this point.
Well, I knew this was going to be a short podcast episode, but modalities are supreme now. They work better than everything else. I'm just kidding. That's not the case. But we'll talk about that in a little bit, whether or not you should use modalities. Okay. So the first, and maybe the most important, ever since we had our interview with Lori Michener, this has had me thinking a lot more about patient education. And we kind of spoke about this before, psychosocial issues, but we kind of knew that psychosocial issues were big in the low back and the neck because they were studied. But as we start studying other conditions, we're obviously finding that it is an issue with pretty much everything, right? And we're starting to find how important patient education is, right? So at least with rotator cuff related pain, if you just educate patients, and oftentimes education includes exercise, so make sure that you note that, the education can be as powerful as actually seeing a patient in person. So one of the things I've kind of doubled down on is looking more at the educational components in these research studies, but also making sure I'm doing a really bang up job with my patients with education because it really seems to be super important, right? So I'm taking a lot of this lesson today from Winters et al. It's a 2021 paper in BJSM. I also looked a lot at the clinical practice guidelines. That was 2019. So, oftentimes what happens is the literature changes over the course of time. So I think the dates become relevant from that standpoint. So largely what is included in these studies that use patient education for patients. So this is basic, and I actually have a link for you guys. If you want to check it out, you can see the exact patient education that was used in some of these studies. But largely, they educated patients on why does your knee hurt? So basic information about patellofemoral pain, what it is, anatomy, so on and so forth. Also risk factors for patellofemoral pain, pushing the importance of adherence and exercise for long-term resolution. In the last podcast show, we talked about how recalcitrant the situation can be. But if you look at studies that compare exercise versus nothing, exercise is definitely superior. So I want to make sure that we really push that. Talked a little bit about when to return to sport and how. We'll talk about that. There's a good paper from Michael Rathliff that I'll discuss in the activity modification session, what you can use to guide your patients. A lot of these patient education packets actually contained exercises. So essentially they had different phases. They said phase 1, do these exercises, phase 2, do these exercises, phase 3, do these exercises as well. So when we talk about education in a lot of these studies, the education actually contains the exercises, right? So we know exercises are very important for patellofemoral pain. So exercises in the education, obviously important, right? They also talked about how to modify physical activity using pacing and load management strategies. More on that later. They talked about pain guidelines as well. And one of the things I will say is that they utilize their own kind of system for how much pain was acceptable. So we use a pain monitoring model a lot, which is 5 out of 10 or less than 5 out of 10 is okay, as long as that you don't have pain after exercise or the following day. And this was a study by Michael Rathliff. Essentially, he wants less than that. So 0 to 2 out of 10 is okay. Anything more than that is unacceptable, right? So keep in mind that this is a little different than most other studies, especially tendon studies. They didn't allow as much pain when they were modifying activities. They also gave information on optimal knee alignment during daily tasks and exercise, and also our good old friend kinesiophobia. Now, this wasn't one from the winter study, but this was a different study, and they were talking about how you can address kinesiophobia successfully with education. So just basically talking to someone is helpful, reduces their fear of movement. And they also noted that certain interventions, which we'll talk about later, like taping and bracing, may be helpful just because it makes patients more confident to do regular activities. And that's a powerful thing, right? So these are kind of the things to go over from an educational standpoint. Once your patient comes through the door, you do their diagnosis. It seems like patellofemoral pain. You want to make sure you're running through these educational components, right?
You know, my patients keep telling me that they have pain right behind the kneecap. Hurts when they squat, hurts down the stairs. I think it's patellofemoral pain. What the hell does the research say about patellofemoral pain? PubMed.com. All right, there we go. Okay, excellent. There's 335,000 studies to read. Gosh, too much. I'm getting frustrated.
Whoa, calm down. No need to be frustrated. This is Dan Pope. I have fabricated what I believe is the perfect solution to your problem. It is the patellofemoral pain evidence-based cheat sheet. And I'll catch you up to date on patellofemoral pain under 10 minutes. Well, I'll tell you what, Dan, that's actually pretty helpful because I'm kind of dumb and I don't like to read. Well, don't you worry. I'm dumb too. But when it comes to patellofemoral pain, I am not. We're going to go over all the greatest hits: definition, anatomy. What the heck is the pain generator? Are there any risk factors for this condition? What's the prevalence and clinical presentation? How about mechanisms of injury, differential diagnosis, how you even go about diagnosing this? And then our favorite, evidence-based treatment. So that's my promise. I'm going to get you up to date on patellofemoral pain under 10 minutes. I'll leave a link below in the show notes in the description. Go ahead and click on that link and get to learning. What do you think about that, Kevin? You disagree, agree, hate education?
Yeah, I thought that was great. And one thing that it made me think about is I've seen you post on this a couple times on Instagram where you ask if going through the injury process yourself is one of the most valuable things a PT can do. And I've been dealing with a hamstring injury on my own, and kind of all those educational things you just talked about are things I have been thinking about with my own hamstring, right? So you could picture the patient coming through the door who just knows a lot less about this stuff. And these are questions they have, and they may not ask you directly, but they're thinking, when can I get back to my sport? What do I have to modify during my life to reduce my pain? What exercises are going to help? How long can I expect to be dealing with this for? These are huge things that, they come to us for. And if they're not asking us, or if we're not educating them, they're going to be looking it up on their own and probably getting, answers that we might not agree with, or things that could be making the situation worse. So, first and foremost, education is like the best thing I think we have to offer. Yeah, I have no doubt if I had patellofemoral pain and I just talked to you for like 20 minutes about it, and you were like, here are the things you want to do, and you gave me all those education points, I think I could navigate it without any intervention from you besides the education, right? So I think it's important, obviously, and yeah, something that when you go through your own injury, you start to really understand, like, pay attention to what you want to know about your rehab process. You can be sure your patients want to know the same thing.
Yeah, for sure. I don't want to go too far off track, but it's so wild how powerful your brain is after an injury, right? Like we're constantly hurting ourselves, right? Like I'll come
Mhm.
in like, jacked up my knee, fell off my bike, twisted
Yeah.
it doing jujitsu, whatever. And the first thing my brain goes to after having an injury is like, crap, I'm gonna have to stop for the rest of my life. This thing is gonna need surgery. Like goes in a bad place, right? And it's funny because like I'm logical, I'm rational, I do this for a living. I tell patients not to freak out about it all the time, but the first place my brain goes is freak out, right?
Yeah.
It's exactly where it wants to go. And I have to look at the research. I have to educate myself again. I have to reassure myself. I have to go through this whole process over and over again, right? And another quick story is I hurt myself back in high school when I was like 17, fell pole vaulting, really jacked up my shoulder. I was going to Rutgers University to pole vault, so it was scary to me. Went to a PT. I didn't get a good diagnosis, didn't get a good prognosis, didn't get a good plan of care. I didn't feel like I was being addressed for my issues whatsoever and stopped. And then literally I just worked with another physical therapist that did a good job diagnosing and told me like, oh, you're going to get better. I don't think it's going to be a problem. Here's the step-by-step, right? And just someone educating me through that process made all the difference. I could buy in and I went for it. So, again, we're just hammering the importance of a really good session with patient education, laying out that prognosis. If people are going to get better, here's step by step. Here's where we're starting. Here's what to do. Here's what not to do. You're going to get better. Just pushing all those things, I just think is so important. So,
One last thing I'll say that I hear you say all the time to patients is that physical therapy is like making soup, right?
mm,
It's that's an important part of that education is that you're tasting the soup as you go and you're adding different things, and you want to let them know that this first session's interventions and exercises, it's not the end product, right? We're like modifying this as we go, and it might take time, and just be honest about that too. We have to see how you respond to these things before we can say that this plan is what's going to get you there. So then when they do have some setbacks, that's okay. You talked about the fact that that's probably going to happen, and we have to keep adding different things to this soup to make it how we want it, right?
for sure. I always tell folks this is experimental. This is our best guess. And I usually laugh and smile afterwards, which I don't know if that makes patients feel badly, but it's you're guessing. We're trying our best here, and we're expecting that it's not going to be perfect, right? If we set that expectation of like, yes, we're going to potentially set you back. This might make you feel worse, but we're learning as we go. And that's part of it. So when patients do hit those rocky spots, they don't freak out. It's like, all right, well, this is normal. We knew this was going to happen. We just have to change it. No big deal. All right, let's next talk about exercise, the best treatment generally for patellofemoral pain. So Kevin talked a little bit about the train on the train tracks analogy. We spoke about this. It's educated a lot in, I think, in university settings, right? So this is a sunrise view of an X-ray. If you guys are not watching this, you're listening to this, I'd recommend checking out the YouTube version at some point. We're basically looking at an X-ray of someone's femur with the patella right on top of it. And you can see that trochlear groove, and that's that track. The patella sits right on top of it. So it's like the train on the train track, right? And essentially, in folks that have patellofemoral pain, they have aberrant motion, which essentially just means they usually move a little bit more from the hip, a little less from the knee. This could be because they have pain. So if your knee hurts, you're not going to want to move through the knee. You're going to move more through the hip. So the hip gets kind of like the blame. Hip's the problem. We know there's weakness in the patellofemoral joint. Weakness in the hip joint after folks have patellofemoral pain. So the natural conclusion is like, oh man, the hip was weak and that's why the knee hurts. We're finding that's not always the case. And really what I just want to push, and I already pushed this in the last episode, is that it's not cut and dry that, oh, you have dynamic knee valgus, that's why you have pain, right? But I will also say that if you have dynamic knee valgus, you do have the femur moving medially. And what that does is it lateralizes stress in the patellofemoral joint. So essentially there's more force or the same amount of force on a smaller surface area. And then over the course of time, when folks have patellofemoral arthritis, it's pretty classic. You'll see this joint space decrease on the side that takes more stress. So the lateral side of the joint ends up taking more stress. There's less cartilage. So natural thought is like, if we can get the knee lined up with the toe, it's going to allow more even force dissipation. Maybe over the course of time, we're less likely to have osteoarthritis. But I will say this is very gray. It's very gray. And the research doesn't always completely support that. And we'll talk about that in a second. So we just spoke about this, but knee in. right? Essentially, if you're doing a squat, and the obvious case, I have a picture of the here again, is if I'm squatting, my knees are coming in, that's going to decrease surface area available for the patellofemoral joint to dissipate forces, right? And this aberrant motion we're talking about in folks that have patellofemoral pain, we might see this in a squat, but we definitely see this in things like step down, single-legged squat, single-legged jump, and landing, right? But you may also see it with things like lunges or Olympic lifts. So we're largely trying to clean up this motion as best as we can. But again, it's not necessarily cut and dry. So I'm about to go into some studies here. Do you have any thoughts on this before I go crazy?
No, yeah, get into it. So far, so good. Yep.
Let's get in. Okay, so a few studies. This is from Dolock et al. This was a study that was included into the clinical practice guidelines, so the American Physical Therapy clinical practice guidelines. The date was 2019, so I think that date is relevant just because obviously this gets updated over the course of time. We don't necessarily want to hang our hat on old research if new research comes out that kind of shows something different, right? So the clinical practice guideline does not suggest using visual feedback to improve patients' motion during things like single-legged squats, lunges, squats, so on and so forth. When I read that the first time, I was like, whoa, that's kind of odd. Why is this? And it was from this study from Dolock et al., which was from 2011, called Hip Strengthening Prior to Functional Exercises Reduces Pain Sooner Than Quadricep Strengthening in Females with Patellofemoral Pain, randomized controlled trial. So first thing on top of my head, this is in females, so it's not in everyone, right? So you don't really know if that's what, is going to be relevant to every single patient that comes through the door. The study didn't even seek to come to this conclusion, although the clinical practice guideline used this study to come to the conclusion, is that essentially they had two groups. One group had visual feedback, so eventually shown to keep their knee over their toe during exercises, versus another group essentially did not have that visual feedback. They didn't try to change someone's technique during things like lunges, step-ups, so on and so forth. So what they found is that at the end of the study, both groups, a group that they tried to change their movement and the group where they didn't change their movement, they just let them go ahead and work into dynamic valgus, whatever, it's all fine. They had the same improvement in pain and function, right? And the other thing they found is that there was no change in their step down between the two groups. So essentially, if you showed people how to do a given movement well, right, and they did that over the course of several weeks, and then you tested a step down, it actually didn't change their movement whatsoever. And this was during a step down, right? And my first thought here is that the reason why folks have dynamic valgus in a step down is oftentimes related to their ankle flexibility, right? We know that. There's a lot of research on this, right? So if you have people with stiff ankles and you have them to do a step down, the reason why they have valgus is because they have stiff ankles. If you strengthen their knee and tell them to keep the knee lined up with the toe and then do the same step down, you didn't address the ankle flexibility issue, right? So that makes a lot of sense to me. And then you have future research. This is from Nunez et al. In 2023. They used internal feedback to try to improve frontal plane and sagittal plane motion. So essentially trying not to have dynamic valgus and trying to move through the knee. And that was part of their intervention for folks who have patellofemoral pain. And what they found is that when you did cue better movement, so less valgus, that did correlate to improved movement mechanics and outcomes, right? So essentially, in this study, it kind of showed the opposite. So it showed that if you cue people to have better motion, right, it does improve the outcome. And then if you test them on I think they used a step down as well as a single-legged squat, it improves their movements, right? So when I first saw that clinical practice guideline, I was like, oh my gosh, that's kind of weird. What's the deal with that? And then I saw this newer research, I was like, okay, well, that makes a little more sense to me. But when I read those two studies, it's like, all right, it's obviously nuanced here, right? And there might be something to movement, improving people's pain, might not be. We're not completely sure. Any thoughts on that before we move on, Kevin?
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Yeah, I guess what I'd take from that is that it's something I'd probably try and see if the person has a reduction in symptoms and they feel better. If it's someone who is going to spend a lot of time in the gym, probably want to work on, I'd want to work on improving those impairments so they can have a better movement selection. They can modify how they're moving to do different exercises better. Like if you're trying to really load the quad, you probably don't want to be going into so much knee valgus, just because you're not getting the same pull on the quad. You're not able to load it as well. So I think it depends on the patient population, and it depends on your goal. But for me, if I have someone that's showing that and they don't have a true ankle mobility issue, and then we change their mechanics and they feel better, well, then that's the way I'll have them squat, or single leg squat. Maybe they feel better with that. Or maybe you throw a little heel lift. They can help with the ankle motion, and then they can squat and keeping their knee a little bit more in that sagittal plane, and they feel a little bit better. Maybe early on they adopt a little bit more of a hip strategy, and then as their patellofemoral joint calms down, we can load it a little bit more, bring it a little bit further forward over the foot, over the toe. But again, if it's someone who they're not interested in being in the gym long term, and we can't find a way to change these mechanics, then maybe that's okay. Maybe we don't have to. But yeah, I'm interested to see how the studies keep progressing over time with more information.
Yeah, for sure. My other thought too is that when you just clean up kind of hip and knee mechanics, you're actually driving more force through the patellofemoral joint. So maybe what we're doing is we're forcing more stress to the area that we want to improve. And that's why we see it improve things. Maybe not because we have less stress through the patellofemoral joint, because we're having better force dissipation. I don't know. It's just, it leaves me with more questions than answers, but it is interesting to see that. Plus, like, we see this all the time, right? Like one study comes out, it's done in a very similar fashion to another study that comes out later, it says exact opposite. So maybe, and I'm not the best with stats, but maybe like the sample size is too small or something along those lines, which in physical therapy research happens all the time. We have these really small sample sizes. So it might just be for that reason as well. But okay. So the next thing I want to talk about is strength the magic bullet? Because oftentimes we'll say, oh, you got patellofemoral pain, we just need to strengthen things. That's what's going to help you out, right? And essentially, the question becomes, does improvement in hip and knee strength correlate with reduced pain and improved outcomes? And this study was from Kim et al. In 2023, Journal of Sports Rehabilitation. Changes in hip and knee strength are not associated with improved clinical outcomes after rehabilitation in individuals with patellofemoral pain, a critically appraised topic. So this is interesting too, because it comes down to kind of our basic science and basic understanding of why exercise is helpful for folks. Because one of the biggest, reasons why folks will say exercise is helpful is because you have weakness and we're strengthening, and then we have increased strength, and that's why your pain goes down, right? Well, this study didn't show that, and like we're seeing more of this research all over the place. There's quite a bit of this research in rotator cuff related pain. So folks go through an exercise program, their pain goes down, their pain doesn't change whatsoever, right? We know that heavy loads work for people in pain. We know that moderate loads work, light loads work. We don't always need to make sure that strength goes up to make a change, right? So this is just a quote from this paper. They looked at 4 individual studies. So they combined a whole bunch of different studies to see. And they said there is consistent evidence that changes in hip and knee strength are not associated with improved clinical outcomes after rehabilitation in adults with patellofemoral pain. So one of the thoughts is like, hey, if we're not getting their strength up, maybe that's why they're not getting better. Well, it doesn't seem to be the case. So you can have increases in strength and not have reductions in pain. You can have the opposite. So you can have folks that have no increase in strength and then their knee pain goes down. So there's something else at play. I don't know what the heck it is, but it just kind of, I think it's good information to know because it just leads you to believe it's not cut and dry, right? Because there's a lot of folks out there say, oh, you're weak, you need to strengthen. That's why you need to get better. It's like, well, we have pretty clear evidence, multiple studies, pretty good studies that show that's not the case. So again, in the social media world, and I say it all the time, you just need to strengthen things. And maybe that's the case, but the strength doesn't necessarily correlate with the outcome. So interesting stuff nonetheless. What are your thoughts there, Kevin?
Yeah, I think that's important to differentiate. Like strengthening might be great for reaching your rehab goal of getting back to weightlifting or getting back on the soccer field or football field, but it may not change your pain per se, right? And then I think you're right. We have to be a little bit careful about telling someone that, you got this pain because you're weak and now we have to strengthen. And if not, you're going to have this pain for a long time. Which is a common explanation. I think one of the more common ones is that you have hip weakness, you have kind of foot and ankle weakness, and then more stress is going through your knee, and we have to strengthen it. But like you said, we have a lot of studies that show that explanation is probably lazy and not exactly true. And there's a lot of things exercise does that we don't understand, right? It does more than just strengthen. It can help a lot of things. It can improve anxiety, improve depression, improve pain, right? So exercise can be helpful for these people, but maybe not just for the sole reason of it's getting you stronger. It's probably doing a lot more than just that.
Yeah. And lastly, I will say is like, I'm not hating on quad strength. I think it's super important, especially for certain populations like ACL reconstruction. We'll talk about this later, but quad strength is enormously important, right? So I still think you should measure it. Still think you should work on improving it. It's just that the reason why we get out of pain is not clear cut. That's all. Still strengthen the quads. Definitely strengthen the quads. Good to do handheld dynamometry testing, so on and so forth. I think it's still probably a good idea to do with your patellofemoral pain patients as well. It's just that, again, it's not clear cut. We're not sure why people are kind of getting out of pain. That doesn't seem to be the exact reason why anyway. All right. Let's talk about the different types of exercise therapy. So largely in our medical research, you'll see a lot of different types of strengthening being effective for folks who have patellofemoral pain. So largely there are a bunch of studies. This comes from the Winters et al. Study in 2021, as well as a couple others, which I've cited if you guys want to check out. So largely we're focusing on strengthening the hip, and that's usually the posterior lateral muscles. So think like glute max, glute med, those muscles specifically. Also strengthening for the knee, which is going to be more quad strengthening exercises. Also trunk strengthening. So think about anterior and lateral core, things like front planks, side planks, so on and so forth. And also a bunch of exercises for the foot and ankle, which I thought are interesting. I just included 2 newer articles from 2023 and 2024, I think. You guys are going to have to fact check me in the reference section, but there's been a few studies since the study from Winters et al. That we're looking at foot intrinsic strengthening by itself, as well as with some manual therapies, I believe, and also short foot training, which is a blast from the past. Vladimir Yanda, right? The old short foot. So thinking that tripod position of your foot and trying to get the kind of first ray closer to the heel and creating an arch. If you use a short foot, it seems to help folks have patellofemoral pain. And working the foot core or foot intrinsics also seems to help as well. So it's funny because we just talked about foot posture maybe not being that important, but when we apply exercise for the foot, it seems to help, right? There's also some cool research coming out about blood flow restriction training. So the clinical practice guideline gave a grade F for blood flow restriction training. And the major reason why is because there wasn't a lot of research out, but keep in mind the CPG is from 2019. There's been more research that's come out since then. So a study by Constantinou et al. In 2022 showed that BFR was as effective as usual exercise of the hip and knee musculature. They also indicated greater increases in strength, reduction of worse pain post-treatment. So what's kind of cool is that BFR, at the very least, can be an exercise that you can use or a type of exercise you can use in your patients with patellofemoral pain that's equally effective as other forms of strengthening. You and I know, if you've been a clinician for a while, folks with patellofemoral pain, if they have bad enough pain, all sorts of exercises hurt a lot. And one of the strategies you can do is you can tackle the hip, you can tackle the foot, just because those are structures we know that don't hurt. And we know if we strengthen them, the patient will improve. But we can directly strengthen the knee and the quad via blood flow restriction training because we're using such light loads. So at least for me, I generally try to strengthen all of these structures. But early on, I kind of hammer the hip, the trunk, the foot. And then I try to use things like BFR for the quad if the patient can't handle normal strength training for the quad, right? So I think that's a great adjunct. And the other piece is that the BFR literature is kind of exploding right now. There's been so many papers in the past 5 years looking at BFR for things like patellofemoral pain. And it does seem promising. So I like it. What are your thoughts on these exercises here, Kevin?
Yeah, anecdotally, I definitely agree with you. I think you made a good point, right? The clinical practice guidelines are from 2019, so things can change, and BFR is one of those categories of studies. One of the focuses of studies that more and more is coming out each year. So yeah, maybe that will change a little bit over time, but to me, it seems like a no-brainer that it's helpful for these folks, and it depends on how painful they are, right? But like you had said, if they're not tolerating knee dominant exercises early on, and you want to get a training effect out of the quads, blood flow restriction is a great modality we can use with people. So, yeah, we use it all the time at Champion for a lot of different things, but usually for those folks that are very irritable and they can't tolerate a lot, BFR is a great way to get a good training effect, and something I'd recommend.
Yeah, it's funny. Like a lot of folks will discredit BFR. They're like, why using BFR? It has the same outcome as regular strength training. It's like, dude, my patients can't do regular strength training. Their knee is killing, right? And the other part is that it seems to help with rehabilitation, but also builds strength and hypertrophy at a very similar rate. In some of these studies, the BFR group actually beats out the regular strength training group, which still blows my mind, right?
Mm-hmm.
But it's just at least as good. And if you have a patient that comes to the door that likes strength or fitness, or they're an athlete, one of your priorities should be keeping their strength and hypertrophy as high as possible, because when they get back to sport, we want to reduce that acute to chronic workload ratio as much as we can and maintain their strength. So BFR, in my mind, despite some of the outcomes being similar to regular strength training, so powerful when people can't actually do much because of pain. Okay. How about some other exercise therapy? So one that did pop up a little bit in that Winters paper was aerobic exercise. And I wanted to learn more about aerobic exercise and pain. There's been a couple cool studies recently about aerobic exercise or walking, namely for low back pain, being very beneficial. And we see that a lot in low back pain. And like, how many times does a patient have knee pain, comes through the door in a physical therapy clinic, says, all right, hop on the bike, let's warm up, right? Is that actually helpful for patients, right? I would love to know. So essentially, I had to kind of dig into this paper to find the actual paper that they were referencing. And this was from Moyano et al. In 2013. And I honestly feel like this paper wasn't completely helpful because they were just looking at static stretching versus PNF stretching with the addition of aerobic exercise. And they didn't even give specifics on what type of aerobic exercise they were doing. They just said it was 45 minutes of aerobic exercise with a personal trainer 3 days per week for 4 months, right? So I was like, what the heck were they actually doing? But what I will say is if you do stretching in one group and the other group does PNF stretching plus aerobic exercises, the aerobic exercises with PNF stretching group did better, right? So is there great research to show aerobic exercise is more beneficial in other types of treatments or nothing? Not really. But I just thought this was interesting. And I like the idea of adding aerobic exercise to my patients' programs. Plus, if you're working with runners, which is a major population who gets this, right? If we can keep them aerobically fit and rehabbing them at the same time, I'm always looking for those kind of two birds with one stone situation. So I would say that aerobic exercise is an interesting idea, but the research is pretty poor on whether or not it helps, right? And then also, you'll see studies that do combinations of different types of treatments and exercises, right? And this is coming from the clinical practice guideline and multiple other studies as well. I think the Winters study said this as well. But when you combine hip and knee exercises, you generally have superior results to doing just hip or just knee alone. However, I will say that this is mixed, right? Kind of always has been. But there's a study in 2023 in the BJSM, and I think BJSM does a great job. Largely, the studies seem to be very good, and I trust them. Is kind of what I'm getting at there. But essentially, they tried to do an exercise intervention looking at the knee versus the hip, or combine the two, and it looked like it was the same outcome, and it wasn't a great outcome either. So that kind of stunk. But largely, keep in mind, this is still mixed, but it does make sense to probably combine hip and knee exercises, or at the very least, choose an intervention that's going to best fit the patient and try to combine multiple interventions. Any thoughts on that, Kevin?
Yeah, I think, like you had said, a lot of the patients that we see with patellofemoral pain are endurance athletes. So they run. Running is a very common sport where we see athletes with this issue. So obviously, they're going to have to get back to some aerobic exercise. But yeah, like you had said, maybe aerobic exercise by itself isn't gonna solve the problem. Maybe we need more research before we say that. But that's interesting because that's not something I had really even thought about. But when you framed it like, yeah, I'll go warm up on the bike, is that something we should be doing with people? So seems like we need a little bit more research there. But again, like you had said there, that hip and knee strengthening seems to be a combination you see in some of these studies that are helpful. So I guess what I'll do with that information is, if I have someone who's trying to get back to an endurance sport, obviously they have to do some type of aerobic activity. Maybe running is too much on the patellofemoral joint right now. Maybe we do something like swimming or cycling if that feels a little bit better, as well as those things that we know seem to be helpful. Maybe a combination of that quad and hip strengthening. But yeah, maybe not something we have to give everybody. But like you said, we're trying to promote health and well-being in our patients, so they should probably be doing some type of aerobic activity anyway. So a lot of ways you could think about that.
Yeah, I'm always screaming this from the rooftops, but like, if we can be more powerful than just helping people that have pain and give them some sort of exercise routine, strength training, aerobics, like, we know those are so beneficial for so many different things. Like, I'm going to try to do that. And my bias, this is my bias. Who knows if I'm accurate, but I can't see a world where doing some sort of aerobic exercise is not helpful for these folks that have pain. It's just a little disappointing, like, with such a common pathology. And I was talking to Rob Mansky about this the other day, like, the amount of biceps tenodesis, the amount of like the long head of the biceps pain that you see does not correlate with the research we have on the condition at all. It's kind of crazy. Like, I really wish there was better research to show and guide us, but I would love to see some more research about aerobic exercise and knee pain, particularly biking, but also running, elliptical, that type of thing. Does that actually rehab patients? Because it seems like it's really helpful for low back pain. Why has this research not been, done on other areas of the body? It's funky. You just haven't gotten around to it. I think the research just hasn't been done yet. All right. So next we'll talk about activity modification. Now I really love this topic here because I listened to a talk from Michael Rathleff. I want to say it was probably in 2019 or 2020, right? Because that's when this study was done. And he brought up this idea of an activity ladder or a modification ladder, right? I thought it was so brilliant that I started immediately using it with all my patients with pretty much every single pathology as a way to do two things. So one, keep people exercising when they do have pain, right? And also as a way to get people back to the activities that were previously painful. So let's say you have low back pain, you can't squat. What can you do that's still like a squat? Maybe it's a split squat. And over the course of time, as you get better, we progress towards a goblet squat, maybe with the heels elevated. And then we work our way to a front squat, then back squat, so on and so forth, right? So Michael Rathleff actually studied this, but it was in adolescents with patellofemoral pain. Like I said, 2019, AJSM, so good journal. And they're looking at 10 to 14-year-olds. So you can't extrapolate this to every single person. Like 10 to 14-year-old, in my mind, is doing a lot different stuff throughout the course of their day than like a 30, 40-year-old, right? So just like take that with a grain of salt, although I still apply these, principles to my patients that are older. They had a 12-week program, and basically they're giving guidelines on how to return to activity during rehabilitation. And what's a little different from what I do and what was done in this study is that they actually didn't start this activity ladder until week 8. So these patients have patellofemoral pain, and they essentially got exercises that were kind of progressive in nature up until week 8. And then at week 8, they started this activity ladder with the goal of being finished the activity ladder by week 12. And they also exercised during week 8 to 12 as well, but they incorporated this activity ladder as well. And the idea is that the activity ladder has progressively more challenging motions. I'll read these off in a minute. And you progress the next level when you no longer have pain during that given step. So there's 6 steps in this ladder. Step 1 was easy walking or cycling at a low level. Step 2 was fast walking or medium to hard cycling. Step 3 was slow running. Step 4 was stair climbing. Step 5 was running and jumping at medium speeds. And step 6 was running and jumping at high speeds. Okay. And this is hilarious to me because this is an absolute no-brainer, which I think most clinicians are attempting to do, or at least they should attempt to do, to return people back to sports. But he just basically researched it, right? So once people got to week 8, they started this ladder. Once they had no pain during the ladder, and they were basically instructed to only perform movements that were a 2 out of 10 or less. I'll get to that in a minute. And when they were at no pain, they moved to the next step, kept on going, kept on going, kept on going. And then when they were able to get through this whole ladder, not hurting, they're able to start sports participation, right? And the last thing I will say is that this is all given during the patient education. So it's not like the activity modification was only up to the clinician to say like, okay, let's go to this stage now. Let's go to this stage now. They were getting this information from the get-go, and they were kind of allowed to make decisions based on how they feel, which I think is an important thing to mention anyway. Any thoughts on this here, Kevin?
Yeah, I like that a lot. I think that's really smart and something I have seen you use with a lot of people. So I think that activity ladder modification is a great practice to implement in all, you could see how you could use that with all different types of pathologies that we see as PTs. So I think it gives a little framework on how to think about that progression of rehab a little bit. So yeah, I feel like that author, he was on so many different papers for patellofemoral pain. So he's a stud.
Yeah, I'd like to get him on. I was going to try to get him on and talk about Osgood Schlatters, because he, is one of the first researchers to actually see if like exercise and activity modification was effective for Osgood Schlatters. I'm sure you probably learned this. I learned this. It's like, all right, you have Osgood Schlatters. It's self-limiting, right? You just push through it as much as you're able to, but nothing's going to affect it, right? It's not the case. But yeah, it's something that a lot of patients are told. So it's growing pains. You'll grow through it. Kind of the case, kind of not. So I would love to get him on the podcast. We'll definitely ask him whether or not he'll be able to get on here is another thing, right? We have our wish list of people we want to bring on. I always try to reach out, but they can't always make it. So hopefully, Michael Rathleff, if you're listening to the Fitness Pain Free Show, we'd love to have you on board. We'll email you in a little bit to ask. You know what I mean?
Yeah. Just quick. I thought this was funny because we talked. You told me that this week, and I'm pretty sure I saw someone like 2 months ago who had Osgood Schlatters, and I told them like, well, it's pretty self-limiting. So I think just to show that like, we're not perfect with this stuff. I'm learning new stuff all the time, and that's where it's so helpful to be surrounded by good coworkers, because I catch the dumb things I say, and then I find out how to get better information. But yeah, I mean, there's just so much to learn all the time. But hopefully folks listening to this can not make, like you say in the intro, same mistakes we make. Because you said that, and I was like, oh God, I think I just told this kid that like 2 months ago.
Yeah. Well, I mean, it is self-limiting in the sense that like every injury is self-limiting. You know what I mean? So I think that it depends on how the patient takes it, right? The patient's like, oh, this is not going to get better, and I'll just push as hard as I can tolerate. Maybe that's not great, right? But if the idea is like, oh, limit your activities based on your pain, and then over the course of time with exercise, it should improve, then that would be, a better explanation of self-limiting that's helpful for the patient, right? And maybe more accurate. But
and that's the way I framed it. Yeah, to be fair,
good.
Who knows if this would just, I guess the thing I was thinking, like with patellofemoral pain, is if we don't treat this, is it just going to grow? Are you going to grow out of it, or is this something that if we obviously if we modify, you're going to feel a little bit better. Modify the things that are most painful, but then what do we need to add to make you better? And that's where I was thinking, just give it time, modify what hurts. Here's some other things to work on. But yeah, we're always learning. So it just funny stuff.
Yeah, it definitely is. All right, cool. So now a favorite of both Kevin and mine. I think it's one of your favorites. Gait retraining. What are your thoughts there, Kevin? You like it? Dislike it?
That's all I think about.
That's all. I catch him daydreaming sometime. Like, Kevin, what's up? He's like, gait retraining. Can't stop thinking about it. Anyway, this was a pretty cool, well, I guess I'm going to bring up a couple different studies, but largely the main author, or the first author on the clinical practice guidelines, was Rich Willie. He's on our wish list as well, right? For patellofemoral pain. He's a running guy, right? And so I don't know, but I feel like he's probably one of the people that kind of tackled this whole gait retraining portion of the clinical practice guideline, right? So The clinical practice guideline, again, 2019, kind of down on gait retraining, just because I think the evidence wasn't particularly strong at the time, whether or not, gait training was helpful, right? And I think that we have seen the research get a little bit more robust over the course of time. But I think it's important to keep in mind there are several strategies to reduce patellofemoral strain while running that have been researched pretty well, right? So one of which is going to be increasing cadence, somewhere between, let's say, 5 to 10%, depending on the study. The one that you're staring at, if you're watching YouTube right now, this was a 7 to 10% increase in cadence. You can also try to adopt a forefoot strike, which we'll talk to Kevin in a minute, whether or not that's something you should try. Talk to Chris Johnson quite a bit about this. Sometimes it can create more issues than it can help, so you have to be careful. Minimalist shoe wear does tend to decrease patellofemoral forces. That's under the pretense that if you have a minimalist shoe, it's not going to feel good to slam your heel into the ground. So you might more adopt that midfoot strike, potentially land a little bit softer, potentially reduce the strain of the patellofemoral joint. You can try to decrease hip adduction or frontal plane movement. So essentially, if you run in front of a treadmill and you're the type of runner that you get a lot of knee in, right? It looks like your knees are kind of crossing over your body every time you take a step. If you try to pretend that there's a little space between your knees, decrease that frontal plane motion, that can potentially decrease some of the patellofemoral strain, reduce pain. And the last one, and this one I had to look into a little bit more because the idea makes sense, but the actual implementation of it, I was curious about, is you can try to decrease tibial acceleration. So essentially reduce the impact whenever you hit. And this study here that I mentioned is called The Effects of 2 Gait Retraining Programs on Pain Function and Lower Limb Kinematics in Runners with Patellofemoral Pain, randomized controlled trial. It's 2024, which I thought was great. Love to see those new articles. Jose Roberto de Souza Jr., great name, was the first author. And I think this was open access. You guys can go ahead and check that out if you like. But essentially, they gave runners a cue to run softer or make their footfalls quieter. And the idea is to decrease tibial acceleration. And they actually had machine biofeedback. They put an accelerometer on the patient, and they had them run in front of this machine that would tell them if they're running with too much impact. And if they're running with too much impact, there'd be this ding, right? And essentially, they're trying to avoid the dings. So they're getting feedback to land a little bit more quiet, reduce impact. And what they found is that this was helpful. So this was helpful in reducing pain, improving outcomes. So I will say, before I let Kevin talk a bit about this, that for runners, I'm almost always trying to alter some of these if it allows them to run with less pain. So cadence being the biggest one, almost always try to change cadence. And then changing running technique, I'm always much more cautious with, because I think you can potentially just trade the stress off from one area to another and end up with a new injury. So I am a big fan of trying to keep people exercising whenever possible. Runners love to run. Some of this gait retraining stuff I find very, very helpful for patients to continue running and reducing their pain. So, Kevin, what are your thoughts on gait retraining?
Yeah, that's all really good stuff. I think I first heard about the increasing cadence through Tom Goom. And I believe when I heard it was an anecdote where he was dealing with patellofemoral pain, and he was talking about, or it was Achilles tendinopathy. I actually can't remember, but it was something where, it was affecting his running, and he adopted this, and then he dove more into the research and really found how this was helping people. But what we think is probably happening when you increase cadence 5 to 10% is, well, a lot of recreational runners adopt a lower cadence. When you increase cadence, some of those parameters you were talking about, whether it's heel striking, sometimes we see increased vertical oscillation that may force you to land in a way that's louder. So louder being a proxy of maybe not absorbing force as well, or maybe you have a little more vertical oscillation, so you're landing louder. The cadence is one of those. It's the thing that seems to change most other parameters. So you can picture if you're running at a cadence of maybe 155 steps per minute, you're going to have a longer stride length. And with that longer stride length, you're going to probably be initiating with a heel strike, and you may be a little bit more bouncy. So if you bump up the cadence for those folks to something like, 5 to 10% more, like you had said, maybe now they're landing with a little bit more of a forefoot or midfoot strike, and maybe their vertical oscillation is a little bit better. better in the sense that it's reducing pain and they feel a little bit better. I think there are a few ways you can think about like what's optimal cadence. I think it, it really depends. But if you look at the professional runners, professional distance runners, because sprinters is going to be way, way higher, but professional distance runners, they tend to sit around 180. So whether that's optimal for every person, probably not. But you look at what the best people do, you can't find any elite marathoners whose cadence is like 160. So if you want to adopt the strategies of the best, maybe you increase your cadence a little bit. This is something that may feel funky for people early on because we self-select a cadence that makes us most economical. But with a little bit of retraining, you become more economical at your new cadence. So that's something to consider. In regards to the minimalist footwear, I could see why that would help, because you're not going to heel strike with a minimalist footwear. Just people tend to adopt a more midfoot pattern with that. But you kind of said this too, I know you talked about this with Chris Johnson. If we cue people to just land on their forefoot, or they adopt a minimalist footwear and maybe they're running a little more midfoot to forefoot, we're just shifting stress potentially, and maybe stress, instead of primarily going to the patellofemoral joint, maybe now more stress is going to the metatarsals or the Achilles tendon if you're forefoot striking. So it's just something to consider, is that if you have someone with Achilles tendon pain and patellofemoral pain, which can happen, and you tell them to start running forefoot all the time, they could just flare up their Achilles tendon. So just something to consider. Stress is stress. And if you're running, it's got to go somewhere, and you can shift it a little bit, but just be aware that you want to know where you're shifting it a little bit. And the last thing I'll say is Rich Willie, who, like you said, would love to have on. He talks about, for people with patellofemoral pain, his return to running programs start with uphill running. And the reason for this is that you are going to be running slower, probably. So less speed is less stress to the patellofemoral joint. And then also your stride length is going to be less. So you're less likely to be heel striking, which could be giving you some problems in the patellofemoral joint as well. So usually for these folks with knee pain, uphill running can be helpful. You can get a training effect without causing a lot of issues, versus downhill running. You have all that eccentric braking forces through the quad and the patellofemoral joint that may be flaring things up a bit. So just something to consider there is maybe we can play around with a lot of these different things in terms of gait retraining. So kind of take your pick and what you and your patient want to work on. But I think, like you had said, you work on cadence with a lot of people. I think that's always a great place to start. And there's a great app called Tap That Tempo, where you can watch your patient run, and every time their foot hits the ground, you just tap your phone and it tells you what their cadence is. And then, you can download metronome apps and you can train like that. Spotify has great playlists that have certain beat per minute songs, so you can train with that too. But that's something worth trying. And maybe their pain goes from that 4 or 5 out of 10 at their self-selected cadence, and then now it's a 2, and that's kind of the pain that we were talking about using for this condition, and maybe they can get a training effect without getting flared up. So yeah, a lot of things to think about, but a lot of ways you could take it.
Yeah, for sure. You already said this. I just rehash. Like you're just trying to manipulate some of these variables so they can still run, right? Which I think is great. I guess 2 things: that at the very least, you can always have your patient say, let's see if we can just avoid hills, right? Second help, not because you're going uphill, but going downhill. The downhill is what gets people, right? Or maybe they walk downhill, run uphill kind of thing. It's also very easy to manipulate this on a treadmill. People hate running inside. I hate running inside, but I do run on the treadmill, especially during rehab. And the last piece is that if you're running uphill, it just trades that stress off. The hip and the calf is taking more strain too. So if you have a runner with a history of like Achilles issues or foot issues, you might bring those on. So you just have to be cautious with these things. We already mentioned that, but I've certainly seen that happen more than one occasion. So just be careful, that's all. All right, manual therapy. Is that helpful for patellofemoral pain? This is always funny to me because recently I've had a few videos about manual therapies that just like exploded, right, on social media. And I use manual therapies, but I use a lot of exercise-based stuff and shockwave, all sorts of things, right? I'm always like referring to physicians. It's like a piece of my puzzle of treating. And I guess I am a manual therapist, right? But it's a piece of everything else I do. But like a lot of folks have like thought I was like a manual therapy expert. I had like 5 people from around the world reach out to me and ask me if I wanted to do a manual therapy clinic. And I was like, whoa, I'm not an expert here. But it's just clear to me that people love manual therapies. It's kind of a hot topic. They like to do it. I think that it's rewarding because patients feel better after you do them, right? But what does the research say about manual therapies for patellofemoral pain? Generally, what I found, and this is actually pretty well studied, there's a lot of research on manual therapy for the patellofemoral joint. Although it's not the highest quality, but I was surprised to see so much, is that it may be helpful in the short term, less than 6 weeks, for decreasing pain in patients with patellofemoral pain. There are several studies integrating manual therapy into a comprehensive treatment program, showing a positive effect. Changes in self-reported function with the inclusion of manual therapy were shown to be significant, but not clinically meaningful. So essentially, including manual therapies might be good as part of an entire comprehensive program. I believe the clinical practice guideline recommended against manual therapies by itself, which makes sense to me. The effects are more short-term in nature, so less than 6 weeks generally. Improvements, long-term results are not going to be better than other interventions. And which interventions were they using in these studies? And these are what I thought were pretty interesting. So, patellar mobilizations. That was the big one. There's a lot of different patellar mobilizations they used. But the other one that was studied quite a bit, several studies, was lumbar spine manipulation or mobilization. And they actually did find reduction in people's pain after manipulating the lumbar spine. And I remember I had a colleague like almost a decade ago that was telling me about this. And I thought that was really interesting. I tend not to manipulate the spine when my patients have knee pain. But an intervention to try. I generally don't do as much manual therapy. I did read a study looking at runners with anterior knee pain, so patellofemoral pain, and a combination of stretch with foam rolling, soft tissue work. And what else did they use? There's some other intervention, but it actually was very, very useful in the short term for patients that have pain. So oftentimes when my patients that have patellofemoral pain, if they're really irritated, I'll do some soft tissue work on their quad, hamstring, calf. And I think that is kind of evidence-based. It's just like, there's not a ton of research on that for patients, right? So I largely find with the manual therapy research, there's not as much research on massage techniques. There's much more research on mobilizations. All that might just be because of the journals that I read. I'm not sure. But, anecdotally, I will use a little bit of manual therapy via soft tissue mobilization. But this is a very small piece of the puzzle to me. And a lot of times I'm skipping this. I'm not doing any manual therapy in my patients that have patellofemoral pain. One interesting thing we'll say, and I'll kick it over to you, is that Dr. Keytrees, shout out to Dr. Keytrees. This is my professor in grad school, David M. Keytrees, did this study in JOSPT in 2018. So I just want to give a little shout out. What do you think about this, Kevin?
Yeah, I think what you said makes sense. And what we see in the research is, when we do see manual therapy, it does seem like a lot of times it's the joint mobilizations. We almost never see like massage therapy. And anecdotally, I'd say it does seem to be a little bit helpful for people. And we work in a clinic where we have so much time with the patient and we're able to do these things. And it does seem helpful for some people. But yeah, long term, it's a small piece of the puzzle. We want to get our patients moving, and we want to get our patients into the gym and back to the exercises and activities they want to do. So, I would say I use it, but I really only use it because of the setting we're in, and we have the luxury of the time with the person. And a lot of times they want this. It feels good for them. But, if we didn't do it, is it changing things long term? I mean, it doesn't seem like it for sure, but maybe it's something that you can try. And if you have an improvement in symptoms, sure, keep it going. But if it doesn't seem like you're making much headway, you probably don't need to be hammering it with the person for the bulk of the session.
Mm-hmm. Yeah, makes sense. Manual therapies are fun. I think they're helpful for some folks. Patellofemoral pain, the study mentioned it, right? They're clinically significant, but are they clinically meaningful? Not in that study, right?
Mm.
And there's a lot of studies they were looking at there too. So they're just taking a bunch of studies, jamming them all together. There's always problems with that. I would say if it really helps your patient, they really want it, go for it. I don't think that's a problem, but just keep in mind it's definitely not the best treatment for sure via the research we have. So if you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. How about other beneficial treatments? Were there any other treatments that were helpful for folks that have patellofemoral pain? And this was coming again from that Winters BGSM study in 2021. So other treatments that were found to be more effective than wait and see was a foot orthosis. So a prefabricated foot orthosis combined with education was actually as helpful as doing exercise and education, which when I first heard that, it made me laugh a lot, right? Because we're thinking so much about, changing people's movement, applying the right exercises, blood flow restriction training, like load management, all these crazy strategies. And it's like, all right, well, give them a pamphlet, put something on their foot. That works just as well, right? Which I thought was hilarious, but I think it's something we can't ignore. So obviously there's way more benefit to exercising, but just putting something inside of someone's shoe has been shown to be very effective as well. So it's also very, very cheap. It's one of those things that insurance companies probably use as a tool against us. We're like, what are you doing exercise for? Just put something in their shoe, right? Obviously, we know exercise is way more powerful for a variety of reasons, but I also think it's important that you understand that this research study did show that, which is pretty wild, right? Also, patellar taping and mobilization has been shown to be helpful, particularly when combined with exercise, orthotics, and education. So kind of combining everything. And lastly, I just said this, but combining everything together can be helpful as well. So if you want to do some exercise, education, taping, orthotics, all these things seem to be beneficial. And when you lump them together, they also seem to be beneficial. Any thoughts on that, Kevin?
Yeah, I think those things you had just said, I'd seen in the clinical practice guidelines, and just bring up Rich Willie again. He has a really good evidence-based course on, I think, advanced concepts in running injuries, something along those lines. And, he has a section on patellofemoral pain and, recommended, as he was one of the authors of the clinical practice guidelines, that we try these things potentially. You try some McConnell taping. We're probably not changing the biomechanics at the joint. It seems like maybe statically you are, but once they start moving, things go back to where they were anyway. But it can be helpful for reducing pain. So if it is, just throw some tape on, teach them how to do it on their own. Maybe it allows them to continue to train with less pain, and they can get a training effect. Same thing with the foot orthoses, or if they feel like they can do their aggravating things now without pain, then why not throw that in as well? So I think this is one of those conditions where thinking outside the box about what other adjuncts you can add could be helpful. And from my understanding, if it's not reducing symptoms, then they don't need to do it. Um, they don't need to splurge. And from what I've heard Rich say as well, and this may be counter to what you just said, is that seems like over the counter foot orthoses can be helpful as well. So maybe they don't need those really, really expensive orthotics. Try it on. If it doesn't help, return it to the store. You just see if it's helpful. And then I think last thing I'll say about that is, we've talked about this, but just because these things seem to help doesn't necessarily mean that their foot posture caused their problems. But I think educating the patient about that is, maybe we're shifting stress while things are aggravated for a period of time. You probably don't need to wear these orthotics for the rest of your life. But maybe it's something for the short term, allows us to speed up this process a little bit. So just something to keep in mind.
Yeah, and I think that Nunez article also mentioned that doing some taping might help with kinesiophobia. I think they may have even shown that, which makes sense. My fear is that if they're scared of movement, and we're telling them that you're only safe when you have tape on your knee, that might be creating some problems as well. But anything you can use that's pushing your patient in the right direction, it seems like these are all good things to try. And at the end of the day, you're just trying to develop a program that's comprehensive, obviously, and follows these evidence-based parameters, but you just make it specific to the patient's needs. You have a lot of options, choose a few. And then over the course of time, you'll find that patients improve, and it doesn't matter too much what combination you use. You have the opportunity to choose what's best for the person's in front of you. All right, so Dan, you just said you can use a variety of exercises, but what's the best treatment? I only do best treatments. What is the best treatment? So the superior treatments essentially were all of these following treatments. So just like I said, all of the treatments that I'm about to list performed similarly. So again, you can kind of try any combination of these. And this is from the Winters et al. Article, so it didn't include every single intervention, but I thought they were pretty comprehensive, excuse me. So they're basically comparing these intervention groups at 12 months compared to wait and see, essentially doing nothing, right? So education by itself performed the same as education plus supervised exercise, because the education group did have exercise, it wasn't supervised. Patellar taping and MOBs. I'm going to repeat this again because if you're not watching this, it can be very confusing. So the first group was education. Second group was education plus supervised exercise plus patellar taping plus MOBs. Third group was education with orthotics. Fourth group was education with exercise with patellar MOBs and orthoses. And the last group was exercise. And all of these treatments had similar outcome at 12 months. And at 3 months, the exercise and education group was superior, right? So if you slap that orthotic into someone's shoe, right, give them a pamphlet, 12 months, they're going to have the same intervention as exercise. But if you do exercise with education at 3 months, that's actually more superior. And last thing they said is that they do not recommend wait and see for the revert to the mean police, right? Was not recommended. So we know that these things are recalcitrant. It's hard to treat them first and foremost. Even when we do treat them, it's hard to get rid of them. When we don't, it certainly doesn't help, right? So those are the best ones. Anything else there? Anything to add, Kevin?
Yeah, the one thing I'll say is that we had, like you just said, we had talked about in the What PTs Need to Know podcast, how common this condition recurs. And, a year out, they're doing about the same, but who knows how they're doing in 5, 7, 10 years out. Is the group that's just getting the foot orthoses and the pamphlet recurring at the same rate? We don't know. So I think, use your judgment, use your, clinical expertise, but I guess my approach would be a combination of teaching them exercises to promote general knee health, educating them on when this might happen again, what things we know you want to modify, and what things we can fill that gap until you can get back to what you want to do. And then if you've had success in the past with your foot orthoses and you get in a flare up, maybe throw that back in there. And, we can work with these patients over the long term to, kind of prevent that recurrence. Our model is that like people can text us with questions anytime. And, maybe that simple communication that we can have with our patients can reduce that long-term recurrence. So I would just be careful about looking at that and saying, it all does the same thing anyway. We just do what, this one thing. And, just think about the fact that we know 5 to 7 years later, like 50 to 75% of these patients may experience this issue again. What's going to equip them with the best tools to get rid of it the next time it comes back as quickly as possible?
Yeah. I'm biased too. Like, I'm not a huge fan of the orthotics, although I will tell people to use it in the short term. I think it'd be very helpful for that. Last thing I will say, again, an anecdote, but this has happened several times. I have a patient on my schedule right now. He has a flatter foot. And like a lot of folks that have a flat foot, their problems are all blamed on their flat feet. And he's basically been wearing orthotic for the past 20 years or however long it's been. He's got some pretty bad posterior tib tendinopathy right now. Cannot flatten his foot out whatsoever in weight bearing because it's so painful. And in my head, I just can't help but think, like, did he get so weak and now he's so unable to move from the foot because he's been posting on the inside of that foot for so long, doesn't have to actually use his foot for shock absorption, right? And completely sheltered that tendon. And now we're having a heck of a time getting that strength back because you're looking at 20 years of potential weakness from that. I don't know. That pops into my head a lot. And I always think the orthotic thing is funny because when you have a surgery, you wear crutches, right? And eventually, like, you get off your crutches. You don't wear them for the rest of your life. Why do you put an orthotic in and keep it in for the rest of your life? Like, we're trying to unload and like kind of shield a tissue from stress. And eventually we probably want to get off of that, right? I don't want to wear an orthotic in my shoes the rest of my life. That sounds horrible. But yeah, it is still an option. So I don't want to poo-poo it. And obviously I have a strong bias against it, but yeah, that's my thoughts there. So lastly, what is not recommended from the clinical practice guideline as a treatment? So knee orthoses, and this is based on grade B evidence that you should not use them. So braces, sleeves, and straps. So like patellar tendon straps, sleeves that you go over top of the knee, different braces, don't appear to be helpful for folks who have patellofemoral pain. EMG biofeedback for the quad. So like that VMO research, like we're trying to get that VMO firing. So let's put like a little electrode on the VMO and then have people do knee extensions and try to get that VMO to activate as much as possible. Doesn't appear to be useful compared to just regular treatment. Visual feedback for knee alignment. Got a couple exclamation points to question marks there simply because we think that visual feedback is probably important, but that's mixed evidence. We're not sure. The CPG kind of hung their hat on one study, which I don't think is a great idea, but it's all we had. And then future studies have kind of shown different results. So I would still recommend trying to correct people's exercise technique, particularly if it helps them with pain, which we know it can. So dry needling had grade A evidence against its use in folks that have patellofemoral pain. So it's a definite non-use. Manual therapy is a standalone, same thing, grade A evidence. Make sure you don't use it on its own. And then our favorite biophysical agents that often make the list of don't use recently: ultrasound, cryotherapy, phonophoresis, iontophoresis, e-stim, and laser therapy. These are not bad treatments, but at least for patellofemoral pain, looks like they're not really indicated. Any final thoughts there, Kevin?
Yeah, just so interesting. I think the dry needling course I took taught about its systemic effects potentially, and then we learned in this that spinal manipulation can be helpful. So you wonder why, like, what is that doing, and what is dry needling not doing? But I'll have to reevaluate my practice because I do all those things all the time. That's all I do is those not to do treatments. So all I do is iso. What is it? Phonophoresis.
Phonophoresis is good. It's when you take your phone and you just put it on their knee. Just around.
Yeah, maybe that's why my recurrence rates are so high.
Yeah, man. Dang.
I have to reevaluate. This was a good episode. I think I'm going to take away some of the pearls you taught me here.
Cool. Yeah. And I will say, like, every time you see those like poor grades, it is, I think, a good idea to go back and poke into those articles and see why, right?
Yeah.
Because oftentimes you'll find it's not really fair, right? It's like, all right, they just gave this a poor grading, and I don't know if that's actually fair, or like what strategy they use, what's the technique, what do they needle, right? Maybe there's other techniques that would be more beneficial, just like you said. So I think sometimes you throw the baby out with the bathwater when you get a grade like that. People look at that like, well, we shouldn't use it. And then no more research studies are done. And then there may be certain techniques are useful in certain patients, so on and so forth. But at least that preliminary research, I didn't read it. I just looked at the clinical practice guidelines. So just so you know that, you'd have to go and check in and see what they said. So, okay, now you have some good idea of the best treatments from an evidence standpoint about treating patellofemoral pain, but you might not know how to put it together. Well, whoop, 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 whoop. There's a link that suddenly appeared over top of Kevin's head. And in this link, if you click on it, there will be a YouTube video from Fitness Pain Free that is about a case study of a patient that had patellofemoral pain, and we abolished their pain. We emancipated them from pain in that video, and I'll show you exactly how I did it. So go ahead and click on that link, and I'll see you in that video. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.